Okay. All right.
Please let me know when you're on.
I know, I appreciate your patience here.
No problem.
All right. We have attendees. All right. I believe we can start.
All right, so we can call the meeting to order now. Leslie, could you get us a roll call?
Yes, indeed. I'm multitasking here, so. Commissioner Bobette Bond.
I am here. Thank you.
Nice to see you. Our new Commissioner Lenitra Grady.
Good morning, everyone. I'm
Good
here.
morning. Did I pronounce your name correctly?
You did. Thank you.
Okay, good. Thanks. Flo Khan. I don't see Flo yet. Okay. Chair Khan.
Present.
Leanne Mcallister.
I am here.
Yarleni Roa Dugan.
I'm here.
Vice Chair Sandy Rubelid.
I'm here.
Dr. Beth Slemowitz is excused today. Dr. Tony Slonim.
Thank you.
Dr. Tiffany Tyler Garner.
Present.
Mason Van Helling is going to join us after a little later, according to Dr. Khan. Tyler Winkler.
Good morning, present.
Good morning. And I see that Flo Khan has signed in. Good
As
morning.
present, thank you.
Now for our non-voting members, we have Ryan High,
Present.
Laura Rich,
I'm here.
Barbara Richardson,
Here.
Richard Whitley.
Here.
Okay, we do have a quorum.
Thank you. So what I would suggest is the new members only who have joined the commission now. Could you kindly just, in a few words, let us know your expertise and background so everybody's aware of it? Leslie, you want to go down the line of the new members?
Well, the only new member that we have since our last meeting is Miss Lenitra Grady.
Okay, Ms. Lenitra, you want to let us know about your expertise?
Good morning, everyone. Again, my name is Lenitra. I am the Chief Medical Officer for 3 FQHCs in the Valley, so a federally qualified health center. I am also a nurse practitioner. I hail from Chicago and have been in Nevada for about 3 years.
Okay, welcome to the commission, Lenitra.
Thank you.
So, being you the only one who's
I am
new.
also new.
Oh, here
Yes,
we
you
go.
are. I apologize, Ms. McAllister.
Go ahead.
My
Leanne
name is
McAllister.
Leanne. My name is Leanne Mcallister. I'm the executive director of the Nevada chapter of the American Academy of Pediatrics. I've been in this role for about 3 years. For 10 years prior to that, I ran a small pediatric practice in suburban Boston. And I'm excited to be here as a patient advocate.
Welcome. Anybody else new joining us? If not, I think we can proceed with our meeting. So Leslie, on our agenda item that I have, the number 1 item is benchmark methodology and value. Is that correct?
No, what we're
That's
going
what
to,
I'm looking at.
well, the agenda that I sent out has for after roll call and approval of the October 2021 minutes is next. Approval of the October 2021 minutes.
So just a question, maybe for legal. The meeting was under the previous format. This is totally newly restructured EPC. Do we still have to approve those minutes as a totally new entity with
Yes,
new mandates?
Yes, we did have a meeting. The only people that are not allowed to vote on those minutes are the two commissioners that were not present at that meeting.
All
Which
right.
was.
Got it. All right, so let's go ahead. Any objections to the minutes that you folks have? Changes, amendments, etc.
Dr. Khan, motion to approve.
Second, anybody second?
I'll second.
Okay, if nobody opposed, then the motion carries, minutes are approved. So Leslie, the next item on the agenda,
Would be public comment. Sorry, I apologize. I'm trying to get Mason on here. Sorry about that. So do I have any public comment? Let me see here. We have attendees, but I do not see where anybody is wanting to make a public comment.
did we get any written comments?
No, we have not.
Okay, so if no public comment from north or south, okay.
Not that I know of.
All right. So the next item on the agenda is for possible action, discussion and vote of commission's adoption of bylaws. So I presume everybody got a copy of the proposed bylaws. Is that correct? Yes, no?
They should have, yes.
Yes.
Okay, so if everybody received it, Leslie's understanding was that the members would send in any written responses for changes, amendments, modifications, etc. She didn't receive any, as I understand, correct, Leslie?
Correct.
So in fairness to the bylaws, because that becomes the format for future meetings, I would suggest that we go down the list of members. We can be brief. If you have no additions or subtractions, then you can just say so, we can move on. And if there are any amendments, modifications by any member proposed, then we can look at that. Leslie, you want to go through maybe in the alphabetical order, like we did for the roll call?
Okay, Commissioner Bond?
I have not read them. Leslie, if you sent them, I didn't review them, so I'm trying to find them now. So I can't vote today, Dr. Khan, but I also don't want to hold things up. I really appreciate that we're creating bylaws, and I really support that we're going to try to be clear about people's conflicts of interest. So I'm hoping that's in there. Maybe I could review them and make any comments for next time, but I would prefer that we vote and get something in place.
Okay, next member.
That would be Commissioner Brady.
Is Commissioner Brady on?
Yes, I'm here. I was able to review the bylaws, but I have no recommendation for any changes at this time.
All right, thank you. Next, Commissioner.
Flo Khan.
Is Flo on? Are you on mute, Flo? Okay.
Yes, sorry. Sorry. Here, I'll turn video on too. Unfortunately, I too have not had an opportunity to review them, so I can't comment at this time. I'm printing them out actually right now, so hopefully I can take a quick peek. Is it possible just to have someone go through the bylaws real quick and just do some of the highlights of it for the whole group, and then we can comment on that? I think it would be nice. I don't know who put them together, so.
I put
Leslie,
them
you want to
together-
comment on the author?
Yes, I put them together with the DAG and with basically used our operating guidelines that the group agreed on, and just added a couple more items that the DAG had suggested, and also that Michael Baylett had suggested that we should have in there. But I'm certainly not prepared to go through the bylaws item by item. That's why I sent them out to you in advance. You know, I'm not an attorney, but I did have the attorneys look at it, and it should be everything that you had already agreed upon. And with just a few additions.
Regarding the reading of this, it's pretty extensive, the bylaws. It'll take us
Yes.
a lot of time to go through them, unfortunately.
Is
Perhaps we
it
should
possible-
defer the vote until the next meeting when people have had time to review it.
We can do that, yes.
I think that makes sense as well, but I do have comments I'd wanted to put in there if that'd be okay, if I could say that.
Okay.
Mm-hmm. Go ahead, please.
So thanks again for putting that together. The kind of just the major things, because it brings up questions about so it does nothing in the powers and duties or even just in the document talks about what our role is and what decision-making abilities we have in regard to the Millbank Memorial Fund and the cost growth benchmark. And I've asked for kind of more direction on this, on what exactly the PPC's role is in regard to the cost growth benchmark, because even this document refers to terms of the program. So are there terms of the program that we need to be operating within? I'm just kind of curious about that. And then just, do we need to spell that out in our bylaws? And then there's, I don't know if we need to talk about the executive director. Our commission has an executive director. It's not, I know it's not uncommon, but it's not super common. So maybe there needs to be something about their role.
Some of the questions that you have are in statute. You know, the executive director was in statute, and as far as your other questions, I think that it would be great if you wanted to write them down and send them to me, and then they could be reviewed by the DAG, because like I said, I'm not a lawyer, and I drafted them because we had to have them, and I had them reviewed, and so that's why we're having this discussion. Michael,
So-
do you have anything you could add to this?
I mean, Tyler, in general, the role of the commission is advisory. And I think that extends to the Peterson Millbank program too, and the cost growth benchmark. And so this body, over the course of 2021, provided recommendations and advice, which ultimately went to the governor's office before the governor issued his executive order. And on the agenda today, we've got additional content specific to the implementation of the cost growth benchmark, where we will be seeking the input, recommendations, and advice of the commission. Is that helpful?
Was that
We can just
helpful?
move on. We can just move on. It's okay.
Okay, who's next online, Leslie?
Well, we kind of went out of order, and we have already two commissioners that say they cannot vote on, or they want more time to read. So I don't know.
Let's
if-
do it this way. Is there any other
Wanna table
commissioner
this?
that would want more time to read it so that we can move on? Could you please raise your hand if any of the commissioners would like to have more time? So if a large number of you folks need more time, then we may have no choice but to table it for today. So at least two didn't have enough time or
We have
understanding.
3.
3. Anybody else?
And excuse me, but Mason Van Helling is on with us now.
All right. Welcome, Mason. So let's finalize this. 3. Anybody else who needs more time to go over the bylaws to be able to vote?
Dr.
So
Khan,
is-
I would
yes.
rather just vote for them and then get something in place, and then we can review them between now and the next meeting and recommend changes if we need to change them. We have the ability to change them, don't we?
I would think so. How about our
Yes,
attorney?
yes, I think that, well, no, I don't know. I would have to ask the DAG, and we don't have the DAG on with us right now, unfortunately.
So I
We
would,
can table it till the next time if you would like.
So just in the bylaws itself, it's the very last article that they can be amended any time by a majority vote of the whole commission.
Okay.
And I'd like to amend what I said, Dr. Khan. I'm sorry to be speaking out of turn. I'd rather have, if we've got an ability to pass them, I'd rather pass them, and then we can bring them up next time if someone has concerns and they raise them with Leslie in a timely way so that we can get them on the agenda.
Right. So you want to make a motion and see
Yes.
that our votes?
Can I make a motion to approve the bylaws as presented today with the caveat that we can review the next meeting if needed?
Do we have a second?
I'll second.
I'm happy to second, but one quick, given what you said earlier in the meeting, maybe someone else can make the motion. Just to make sure, given that you haven't read them, somebody else should probably make the motion to make sure that we go forward, and happy to do that, just to make sure we carry on. I also want to compliment, I think that the document is nicely done. I think that it's, thank you, Leslie, and thank you to the team who put it together. I think it outlines the work and addresses some of the challenges that we've had before, because we didn't have kind of standard operating procedures. And so I want to throw my support and appreciation behind that as well. Thank you.
So is there anybody opposed to this motion?
No.
Okay, so then the
Okay.
motion carries. So to summarize, we have approved the bylaws with the caveat that we have the option to change them and potentially put it on the agenda next meeting. Please, I would request everybody to come prepared or send them in advance to Leslie so they are available so that the meeting can go a little more efficiently next time. And we don't spend too much time because we haven't had a chance to read. I understand there was some confusion that people had in their mind regarding reviewing it and having their comments ahead. So moving right along.
Wait, Leslie, can you please put Commissioner Khan as abstain on the vote?
Sure.
Thank you.
Okay. I can do that. And so we had the motion from Bobette Bond. Do we want to keep it that way?
I'm comfortable with it. I appreciate the
Okay.
work being done, and I was, I'm more concerned about having no bylaws in place, frankly.
Okay. And Commissioner Slonim seconded. Flo Khan is abstaining. Is everyone else in agreement?
That's what I noted.
Yes.
Okay. All right.
Okay, moving right along to our next agenda item. Leslie, you want to pick it up there?
Yes, the next agenda item was just a vote of the commission to continue our stakeholder advisory subcommittee. Those committees are only to last for 6 months. And that committee was formed in May of last year. So in order to keep their work going, you, the commissioners, just have to have an agreement that you would like to continue the Stakeholder Advisory Subcommittee to the PPC for the Peterson-Milbank Program for Sustainable Healthcare Costs.
So for the new commissioners, a quick question. Are you folks familiar with this committee? If you are, then perhaps we can vote. But if you are not, then please let us know now.
You know, we got to watch the lovely recordings of last year's meeting, so I feel well informed.
Okay, excellent. So everybody's comfortable with us voting for extension or otherwise? Okay.
Yes, Mr. Chair, this is Mason Van Halen. I'd like to make a motion to continue our advisory group and continue that work that they're doing.
Great. Is there a second?
Tony Sloan, I'm happy to second.
Okay. Any opposed? Hearing none or seeing none. So the motion carries to continue this advisory. All right, let's keep moving. Leslie, next item on the agenda.
The next item would be the review of the executive order. Michael Baylett was going to handle that portion.
Is
Michael,
Michael
you're
on?
mute. Oh, okay, he's sharing, okay. Okay, well, the invite,
Okay, shall I proceed?
So
yes,
a quick,
I don't know what's going on
good-
here.
Can you
So
see
is
my
that-
slides, Leslie?
We see
Yes.
presenter view.
Oh, okay. Let me fix that. All right. Can you all see me now? Or see my slides now? Great.
Much better.
All right.
So a quick comment before we start. In the interest of time, as you know, I'm very particular and respectful of everybody's time. This is a voluntary commission. So if you can kindly just summarize everything, because what takes time is the commissioners have a lot of
Yes.
question, and rightly so.
Hang on,
So. Hello?
Okay. I will move as quickly as I can.
Yeah, and because the commissioners will have a lot of questions, and I think it's important to have everybody's input.
Sure.
All
So
right.
just as a reminder, during our last meeting in October and also during the last advisory group meeting, there was general agreement that gross state product and median wage should be used to calculate the benchmark. There was not consensus on a recommendation. Within the PPC, there was interest in a cost growth benchmark of 2.4 or 2.8% for 4 or 5 years. Most people preferred a constant value over that time period, and your input was conveyed, your recommendations were conveyed to the governor's office. So I just want to give that background. The governor issued an executive order on December 29th, and it set forth cost growth benchmarks for 5 years. Consistent with your recommendations, it considered both median wage and gross state product, but it did not set, the governor did not set a constant value as you had recommended, but rather a step set of values based on varied weightings of median wage and gross state product. So you can see here for this year, 2022, median wage is weighted 20%, gross state product 80%, and by 2026, the weighting flips. So the 80-20 goes the opposite way. Okay, I want to review other elements of the executive order. It's not very long. It applies to all healthcare markets and the whole state population. It directs state agencies to implement the work within the scope of their legal authority. So they're required to monitor spending growth for public and private payers and report annually to the governor, to engage an array of stakeholders to develop strategies to help meet the benchmark. It requires reporting annually in the fourth quarter on performance for the prior calendar year and for reporting to be at 4 levels: the state, the health insurance market, and individual payer levels, and also at the accountable care organization level. Now, accountable care organization is consistent with what we had talked about as being large provider entities does not define accountable care organization, but I think it's intended to be consistent with the large provider entity discussion that we had had. And then in almost 5 years, 4.5 years, it directs the PPC to make recommendations for the value of cost growth benchmarks for year 2027 and beyond. And by the way, I want to note, these slides are posted on the commission website. They are slightly different than the ones that were distributed to you in advance of the meeting, just so you're aware. Okay, then finally, the executive order specifically names the Division of Insurance, the Department of Health and Human Services, as agencies, among others, that shall coordinate this work with the commission and with its executive director to implement the order, and says that should the commission find that there have been significant changes to the economy after the effective date of this order, which is the end of December, it may recommend to the governor changes to the cost growth benchmarks, or recommendations to changes in which benchmark performance is assessed. Now, we actually haven't talked about how benchmark performance is assessed. That's on our agenda for today. And then finally, the executive order remains in place unless amended, modified, terminated, or rescinded by the governor. Okay, so let me pause there and ask for questions and comments on the executive order.
Is our chair here to, or we don't have a chair for a minute, so I think people
No,
are.
But I see Tony's hand up.
Yeah, my hand's up too. Let me make my hand.
Okay, I'll go next to you, Puppet.
Thank you, Michael. Always appreciate the conversation and the summary. Given where the executive order is, I'm also wondering, things continue to move in Nevada. Certainly, we are. I'm particularly struck by Section 6 of the governor's executive order here, because I think it's highly relevant to where we are in the midst of this ever ongoing pandemic.
Sure.
Nevada, like many other states across the nation, is in crisis. The pandemic is not just an acute issue, it's chronic. The workforce issues that we're seeing in the community are, and the workforce challenges are halting our ability to care for Nevadans in and outside of the hospital. We have hospitals closing beds. We have doctors leaving the workforce. We have nurses leaving the workforce. And I'm concerned, but for one person, about the implications of both supply chain costs, testing costs, new unfunded mandates coming from the federal government, like testing obligations on payers, where if someone who's insured wants a test, they can get a test, all in setting a new context. It seems as though we're trying to address cost, certainly an important thing, but we're doing it while the world around us is moving in chaos, and we have not yet figured out how to do that. That's a long way of saying, particularly given what we're seeing here in Nevada, has there been any conversation with the governor about modifying or addressing where we are right now in benchmarking and thinking, and we're still trying to battle this pandemic and healthcare. We started from a place where, as we've talked about before, healthcare quality in Nevada ranks in the bottom 5% of the nation. We've got some examples in the pandemic where it's gotten even worse. The state ranks dead last in mental health. Access has been compromised and is getting worse, and costs keep going up because of workforce, labor, supply chain, etc. So it seems as though we're almost in a different place than we were when we started the conversation, and we've got an executive order to manage. So give me some, if you could, some backdrop to how that all of our context has been used to inform the governor. Thank you.
So, Tony, if I may quickly make my comment is reinforcing what Dr. Slonim has just said. Literally, there is a crisis situation on the ground. We went through one several months ago, and now which is a repeat one, probably worse in some ways than the other. When the patient access becomes a problem, where the patients are turned away and sent home, where they would have normally perhaps been admitted only to come back a few days later. It has created a crisis. Also, in terms of patient protection in various concepts, the nursing shortage is acute. In the hospitals, from what I understand, talking to the various folks in the hospitals, and there's no way to find them nationally, no matter how strongly the hospitals are seeking out to find the nurses, and that compromises the patient care, which was already of concern to everybody anyway. So just my 2 cents worth that we are at a level of crisis. This sort of has to be incorporated somehow between the long term and what happens in the short term when crises like this happen.
Yeah.
Go ahead, I'm done.
Babette, can I respond before we go to you, or would you like to comment first?
I would like to comment first, and then I'd like you to, then you could respond to all of us if that's okay.
Sure, of course.
I would just like to say I would just like to amplify what Dr. Khan, our chair, just ended with, which is this is a long-term game. This is a long game. This cost management or cost, it's not even management, it's just like review and having some eyes on what we're doing with healthcare and setting some targets for what would be better is a long time coming. This is a 10-year effort to try to at least get our arms around what's going on with healthcare cost escalation. And I understand what Dr. Slonim is saying about we've got quality issues, we've got staff issues, we've got manpower issues. We always will. They are acute right now, but I don't think that you change the foundation of your of the pillars that we're trying to put in place for healthcare management in an acute situation. I think you add them to the general trend, and if it's clear that the trend is not going to be met, we review why that is. That's the purpose for monitoring the trend and trying to set a benchmark. I don't think that we should be mixing that conversation about this long-term benchmark up with our current acute situation. I think we should have separate conversations about what's going on with our acute situations in Nevada. And I don't think they specifically relate to this long sought goal of trying to at least start working on a common, a common goal.
Yeah, I think you're all right. I think, Tony and Chair Khan, that what's likely to happen across all the states that have cost growth benchmarks is that they're going to review spending trends for 2021 in context of the crisis that's occurring right now, and recognize what a crazy time period this is. And I think Babette's also right that this is a long game, and the idea behind this strategy is to focus on long-term sustainable rates of spending growth, despite what we're going through right now and the workforce and supply chain problems that are just so problematic.
Hi, this is Mason. Chair Khan, do you mind if I kind of, just to make a comment? I know we're reviewing the slides, and definitely I think we all agree this is a long endeavor with a lot of analysis related to data and making decisions and improvement in our state. And I think all of our commissioners on this topic here, where we've paused, is there a way to agendize and perhaps reprioritize some of the things that we set out early on our charter? And I know we've got some new members, and I know they've done a great job of reviewing some of the early information, but we did set out with some principles. And I think me personally, seeing what's going on in the hospitals on the front lines, supporting patients. Is there a way to agendize some immediate expedited actions to just make sure that we're doing all that we can? That the governor's depending on us, and we've got to take this conversation, even though it's kind of data analysis and long-term strategies. Is there a way to take some of this now, or even look at our current charter and our priorities to say, what can we do immediately to make an impact and change? So that's just kind of my 2 cents, but I know maybe at some point we could revisit our founding principles that we spent many meetings on. So I just don't want to, and certainly agree that all things around cost and inflation are here to stay. Who knows for how long, but we certainly need to take that into consideration. So, but I appreciate the conversation, but I know if we can leverage our strength of this commission to do some immediate expedited things to protect patients and access and all those things that we had discussed, I think we need to somehow agendize that. Maybe it's under emerging issues, but I appreciate being heard on that and appreciate by other commissioners too.
Any other commissioners with a comment? Any other commissioners have a comment? Doesn't look like anybody else has a comment.
This is Tony again. I would just say 2 additional things I think which are highly relevant for the conversation. 1.1, we've talked about workforce. Workforce is a major contributor to overall expense in managing the state of our health. We know that we have a historical perspective of being 200 per 100,000 nurses below the benchmark in Nevada. 200 per 100,000. Just this past week, the governor initiated some work that helped us to address this nursing workforce crisis. We don't have nurses at the beds. We're closing beds in our hospitals in northern and southern Nevada because there's no opportunity to care for people. And the same thing goes over to the issue of physicians, where we've had a workforce shortage as well. In that context, our ability to attract labor, skilled labor in the healthcare space to Nevada is becoming maybe compromised further by virtue of some of the work. Point 2, God help us if you happen to be, again, the name of the commission, Patient Protection Commission, God help us if you happen to be a resident of rural Nevada right now, where there are challenges. On a good day, there are challenges around workforce. On a good day, there are challenges around access to skilled labor to keep patients in their community and healthy and care for them when they're sick. And these people are struggling beyond what you could even imagine. And I'm worried. Now we're going to add another thing on. And the third thing I'll use is a metaphor. It's a clinical metaphor. I'm sorry for that, but I've used it before and I think it's relevant. I appreciate the long-term perspective on this, but as a physician, I'm really worried about advocating for the people who need care when they need it. And it seems to me that the focus right now on cost, addressing cost, is a chronic issue. It's almost like dealing with constipation in a patient while we're doing CPR. In our context in Nevada, we've had a fever pulse for a really long time in our healthcare system. The pulse has gone away and we're doing CPR, and yet we want to impose another layer of cost reduction work that people have limited bandwidth to accommodate right now. They are overworked, they're overwhelmed. Everyone in the country is fatigued from the pandemic for 2 years. And while we all thought it was going to be gone in 6 months, it continues to persist 2 years later. The industry suggests that this is a 5 to 10 year recovery. And in the meantime, we want to continue to layer on top of that efforts around cost while we have not addressed patient protections. And I think as a commissioner, I would have a hard time defending that approach.
Any other commissioners' comments? I would like to hear from some other commissioners.
Well, Dr. Khan, you just heard from Dr. Slonim twice, so I guess I would request that I be allowed to go twice as well.
No,
I'm happy to
which is fine. The reason I recognize them because there was a silence when I asked any other commissioners. So I guess he took the opportunity to chime in, and certainly you can do that.
Yeah, I thought well, I'm just confused about what agenda item we're even on, because I thought that are we still talking about the executive order and Dr. Sloan's opposition to the executive order? Okay, well, I would like to move off of the executive order, because if we could finish that work, it would be great, because I think the issues that Dr. Sloan is raising are very interrelated with our long-term foundation, and we just have fundamental differences about this. I think that the healthcare system is largely in crisis because of the escalating healthcare costs that have been unchecked, unmanaged, and non-transparent for a couple of decades. So I think that's an integral part of what we have to handle, and I think that ignoring that is something that we've done for a long time. So I really appreciate that it's actually on the agenda of the commission and that it's been a factor in the commission. Putting it to the side and not addressing it while the rest of the system is having a difficult time. There's reasons related to price that the system's having a difficult time. And I think that we should acknowledge that as well. If we're going to have a conversation here, that's a holistic conversation. So whatever we can do, Dr. Khan, to close this item and open what I think what Mason has suggested from UMC about agenda item news items. It seems like a lot of this goes there.
Yeah, so I appreciate, before I comment, is there any other commissioner wanting to speak?
Yes, this is Dr. Tiffany Tyler Garner. I have my hand up. Are you able to hear me?
Leslie, are you watching for the hands up? Go ahead, please.
I just want to note that I don't believe that this situational context that the work is happening now should preclude us from having some aspirational expectations or benchmarks for healthcare cards. And I don't believe that they have to be in competition with each other, those two aims. And with the attention in the executive order to ensuring affordability over time, I believe
unfortunately, I'm having a lot of feedback on my end, but we have Sandy and Tiffany Tyler Garner have their hands up.
Leslie, Tiffany was talking.
Yeah, Tiffany's talking. Go ahead, Tiffany.
I'm sorry, I don't know if you were able to hear my brief comment, which was that
I was. How about the others?
Yes, we could hear.
Okay.
It would be great. It'd be great if she's allowed to finish. I'm not sure we got everything she was trying to say, and I really appreciate it.
Please complete your thought.
So just as a brief recap, I don't believe the situational context in which the work is happening now should preclude us from having some aspirational benchmarks for healthcare costs, and believe that the attention to affordability that the model suggests over the 5-year period will help us in addressing not only the concerns that Dr. Sloan have noted, but also some real expectations for the level of care and quality that should be happening statewide for children and families. And so while I appreciate the latent effects of this pandemic, I want to say that should not be in competition with us having some aspirations for the quality of care or its affordability.
All right. Thank you. Who else is in line? Leslie? Leslie, can you hear me? Anybody else with a hand up or wants to speak?
Dr. Khan, this is Sandy.
Okay, Sandy.
I just wanted to agree with the comments that were just made and remind everyone that, the governor's directive was to work on this executive order. So we need to not have these be in competition. And there is an agenda item later in the agenda where we can add future agenda items. So that might be a good spot to discuss additional items that we want to tackle in the next commissioners meeting.
Okay, any other comments before I sum it up?
Dr. Khan, this is Yardleni. I just would also like to chime in and agree with Dr. Tyler Green and Mason, as well as Bouvet, on how we need to think in the long term as well as the acute problem that we're having right now, and adding it to the agenda later on would be a great start.
All right. Any other comments?
Just one comment, Chair Khan, and again, just,
Johnny, we need to move on.
yeah, no,
Go
I
ahead.
appreciate. All I'm going to say is this: the only reason why I raise this in the context of this agenda item is because of Section 6, which Michael just covered, which is the order is effective upon signature and remain in force unless amended, modified, terminated, or rescinded. And the question is, should we be offering to the governor that, given where the state is, we should ask whether or not he's interested in modifying his order? That's the reason why it was brought up in the context of this agenda item, not to, say, hey, there's a whole bunch of other things, but that's the thing that caught my attention and what led to my interest. Thank you.
Okay, thank you. So I think, let me, in the interest of time, summarize it. I think I agree with the majority of the commissioners that this long-term issue that has been on the agenda today is crucial and should be obviously prioritized given the governor's executive order. Having said that, I also believe what Mason mentioned, that the sooner this short-term crisis is also addressed one way or the other with an agenda item at the next meeting, which hopefully is within a month and not too late. And somehow we can address that issue, and whether the presenters today have any thoughts to consider that as a part of it. And of course, the governor can certainly let us know what our proposal may or may not be at the next agenda item discussion to address that, whether it should be a separate issue for the governor's attention, or it can be incorporated as a part of this long-term issue. So the Bailiff people, if you can just let us know what your thoughts are. We should have it as a separate agenda item next month rather. That'll be great. So I need your opinion.
I think adding this as an agenda item next month makes a lot of sense.
Okay, anybody opposed to that, to request next month, which will be publicly put up so that we are in compliance with the law?
What is the agenda item being suggested, Dr. Khan? I'm sorry.
Yes, I need some clarity on the Mason. Would you want to elaborate since you had mentioned about it?
Dr. Khan,
Yes.
This is Sandy. There's a separate item on this agenda where we talk about future agenda items. So do we want to wait for that?
We can do that. Bobette, is that fine?
I would rather, so that everybody's agenda items can get tucked together in the agenda item. That would be great.
Okay, if nobody has any objection, we can discuss this, come back to it for future agenda items. Does that make sense to everybody? Okay, so I think we'll talk about this next agenda item, and everybody can chime in again, specifically what that agenda item should be, to your point, Babette, and have the language of the agenda item during that discussion. All right, so go ahead, please proceed.
Okay, so our next topic is going to be a discussion of how to report performance against the cost growth benchmark. This is something that we've not talked about before. So just as a reminder, there are two different forms of analyses to take place as part of the benchmark program. On the left, we have an analysis of performance relative to the benchmark. That measurement is to occur annually using payer-collected aggregate data. The source of the data is insurers and public payers, specifically Medicaid fee-for-service and CMS fee-for-service, but potentially other smaller, lesser payers, and staff from the DHHS Office of Analytics have been assigned to this work. That's what we're talking about today. Separately, there's analysis conducted as part of the data use strategy that uses granular claims level data to get a more nuanced understanding of what is revealed at a high level through the benchmark analysis. We are not talking about the data use strategy today. We will in future meetings. Today, we're just talking about the benchmark analysis. Leanne, I see you have a question, or at least a comment.
I do have a question. Is it possible to also include provider data? So administrative costs is such a significant part of healthcare spending. And as a former practice administrator, I can tell you that there are a lot of legitimate claims that never get paid. And that is not then part of this conversation and benchmark data, the sunk cost of chasing after claims that never get paid.
Yeah, so in our much earlier meetings, when we defined healthcare spending, we defined it as dollars paid by payers and not costs incurred by providers. So I hear what you're saying, but previously this body adopted a recommendation to measure spending based on payments that come out of payers and consumer shares of the payments.
That cost is also incurred by patients, right? Chasing unpaid claims.
Sure. Yeah. No, I recognize it. It's not part of the definition. And I'll say it's also not part of the definition that any of the other cost growth benchmark states have adopted. Tyler?
So I think to give that some context, because we did talk a lot about getting more provider data, but we kind of landed on there wasn't an easy way to do that other than self-reporting the payers. It's just easier to collect that data from them. But it is something we did want to try to look at.
Right. Yeah, we have talked about it. I acknowledge that. Okay. So as a reminder, we've talked about this previously, although not for quite some time. There are 4 levels of reporting. It's actually called out in the executive order. The state, the insurance market, which we define as Medicaid, Medicare, and commercial. The payer, which would be Medicaid, managed care organizations, Medicare Advantage plans, and commercial carriers. And then large provider entities, which are referred to as accountable care organizations in the executive order. You'll see at the top underneath state market payer and large provider entity, it says THCE and TME. So THCE stands for total healthcare expenditures, as a reminder, which is both payments for medical services and also the administrative costs and margin of health plans. And TME, total medical expenses, just payments for medical services. Okay, so 4 levels as an example. So I want to give you some examples of how other states have done their reporting and analysis before we get into some of the strategic questions that I'm going to pose to you. So this first example is of state level reporting. This is what Delaware did when they reported their 2019 spending. They looked at total spending. They broke it out into the categories that you see here. This isn't reporting on trend, it's just reporting on the breakdown of total spending. The next example looks at trend at the market level. So this is from Rhode Island. Their cost growth target for 2019, or cost growth benchmark, was 3.2%. They exceeded it for their commercial market, where trend was 4.7%. And in this presentation, they actually valued what was the dollar amount represented by exceeding the 3.2% target. And that was about $32 million. This is an example of reporting at the health plan level. This comes from Massachusetts. Their cost growth benchmark was 3.1% for the time period being measured. And all those circles are health plans. You can see some above, some below. The size of the circle indicates the size of the insurer's market share. Just another way to to present information, but this reflects reporting at the payer level. And here's an example also from Massachusetts of reporting at the provider level. It's a little confusing because they report at the provider level by insurer. And you can see for individual provider organizations, sometimes, well, frequently, the experience by payer is mixed. So sometimes the spending growth is negative, sometimes it's positive, and it varies a lot by payer. And the organizations you see here at the bottom, Partners, Steward, Atrius, Bidco, those are all large provider entities or accountable care organizations as described within the executive order. Okay, so these are the different levels of reporting. These are just some examples of how other states have done the reporting. So let's get into some of the policy questions here. So per reporting at the provider level is the most complicated part of doing the measurement because it's limited to providers that are sufficiently large that measurement of performance against the benchmark can be done accurately and reliably. If a provider organization is really small, we really can't have a lot of statistical confidence in our measurement. In addition, we need to focus on provider entities that have responsibility for meeting all of a patient's needs. So this isn't going to be a specialty medical group or an outpatient imaging center. It's going to be a medical group or a health system or an independent practice association that has the ability, even if they don't, to engage in contracts for the total cost of care for a patient. Tiffany?
Just had a clarifying question. Because the reporting would happen in aggregate, the impact of it being a small provider is in some ways mitigated, right? Or no?
Can you explain a little further what you're saying?
So you're noting the challenges of it being a small provider and the impact maybe on sample size or something of that nature. I'm not sure.
Yeah, right. So with a small population, you're going to get lots of random variation. So you could get a swing where spending growth is 20% one year and negative 20% the next year. So you need a very large population to get some statistical stability when you do the measuring.
Because there would be multiple providers that we would, as the data set would be comprised of multiple providers, does that somehow mitigate the inclusion of smaller providers as a part of that sample? Because you're not, you're looking at this measure across several places, right? But this data set together is a larger data set. Does that make sense?
Right. So if you have an aggregation of individual providers who are part of one larger organization, then they are going to bring with them more patients, and the larger the patient population, the more reliable the measurement.
Okay.
Okay. So we need big populations to do this at the provider organization level, which means that you're going to be limited in terms of the number of organizations you can measure.
Okay. Thank you.
Yeah, great question. So, something I'm sorry, Tony, go ahead.
Just a quick follow-up on that, Michael. That's a really important point that was just made. In that conversation, then, if I'm working on the statistical piece of this, the larger groups will then tend to set the tone around what the mean is. And the smaller practice groups will more likely be outliers because the tendency towards centricity would be defined by the larger groups mathematically. Accurate?
Well, so because we're doing the measurement at the 4 levels, ultimately we're going to be measuring it at the state level. So, are the larger groups going to have a disproportionate impact on total spending? Yes, but we're still including, the smaller providers and the patients who are not served by the large providers. And typically there are a lot of them. So when we're doing sort of system level measurement, you're not going to get the largest providers defining what the trend is.
Okay, good. So if I follow up on that last question that was asked, it wouldn't be that the smaller practices would be looked at more as outliers, even though they've got lots of variability. They're not going to be outliers. We want them to be inliers to the degree that their practices are, right? We would not want, let me say it differently. I wouldn't want to disenfranchise smaller group practices because the normatively is created by the large group practices.
Yeah, so what we're going to do is actually we're going to exclude the small providers from measurement of performance against the benchmark. Okay. Babette?
Thank you. Can you hear me?
Mm-hmm.
I see your second bullet point, so maybe you're going to get to it. I could hold this. I think that as we're talking about provider size, one of the things that's been happening is this consolidation of the industry where hospitals are buying a lot of practices, and we can work on that as part of the PPC as well, but practices are consolidating with each other, and there's a lot of private equity money that's entered the market where they're buying the practices, and I think that might be something that drives up some of the utilization, but I don't know if it's going to be captured at all in this work, and I just should have asked last year when I first started thinking about this. How does this roll out when we get data on how does it link to ownership?
So, I mean, not directly. We're about to talk about how do we identify provider entities to be measured. We separately are going to talk later about cost growth mitigation strategies and what recommendations does the commission want to make to ensure that the benchmark is met in future years. And so, maybe some of your questions are going in that direction. We're not going there today, but ultimately after the benchmark's established and we've decided how we're going to do the measurement, a lot of the focus is going to be and what policies should be advanced to make sure the benchmark's met. Does it have to do with practice ownership or market consolidation? Maybe that might be something you all want to talk about.
But we can't get that data about ownership out of this data from the benchmark.
No.
It won't come. Okay, that was my question. Thank you.
It won't come out of this data.
Thank you.
Yeah. Flo?
I just have a question about how, in terms of the reporting and identifying who, how do we address the rural areas in this? Because a lot of those might not be large. How do you ensure that we're capturing all of the different regions?
So you're right. The small providers in rural areas probably aren't going to be measured relative to the benchmark because they just don't have enough patients. But you remember that slide I had a little earlier where I divided between benchmark analysis and what I called the data use strategy? So the data use strategy is using claim level data to understand what's going on underneath the benchmark. And one possible analysis is to look at spending trends based on geography. And in fact, I know that some of the analysis that DHHS has been doing has looked at growth rates or trend rates in spending in Medicaid based on geography. So that's a way to bring that perspective. It's probably not going to come through our benchmark measurement, but it can come through the supplemental analysis. That's part of what I call the data use strategy. Okay, so we need to think through how to define and identify which provider entities should have their performance measured against the benchmark. We're going to come back to that later. All right, so the first thing that I want to talk about is this concept of attribution. Oh, Tiffany?
I'm sorry, I had a clarifying question, and it may not be appropriate or germane, but it's a follow-up on the last question or comment. I'm wondering if there is a way that we can account for the experience of some of the smaller providers to support the system toward even ensuring that they could hit that aspiration, and what that would look like in terms of reporting. So is there an ability to maybe have some kind of parallel reporting process that incorporates their experiences in terms of the benchmark, so that we're also accounting for affordability and some of those other considerations in those communities as well?
Yeah, so it's common to do reporting on sort of everyone else. So you measure for the large provider entities, and then you capture everyone else who doesn't fall into large provider entities. So we can look at spending growth for those smaller providers aggregated together.
I would encourage us to do so if we haven't settled on that, or if it's isn't part of the methodology.
Yeah, that's standard in terms of how other states collect their data from payers.
Perfect. Thank you.
Sure. Okay, so I want to talk about this concept of attribution. There are two questions here. How do we attribute patients to a clinician? Meaning, when I say attribution, how do we establish a relationship using data between a patient and a clinician? And when I say clinician, I really mean a primary care clinician or a primary care provider or PCP. I'm going to use clinician and PCP interchangeably. Okay, and when I say PCP, it doesn't have to be a physician, right? It could be a nurse practitioner or other primary care provider. So that's one question. How do we connect patients with clinicians? And then how do we connect clinicians to larger provider entities for the purposes of measurement and reporting? So I'm going to walk through both of these questions. So in this exercise to measure performance against the benchmark, we need to make a whole bunch of connections. So first, we have to attach spending to individual members of a health plan or payer. And then the members have to be connected to a PCP. And then we connect the PCP to the large provider entities. Okay, this is the chain by which we get to measuring provider entity performance against the benchmark. Dollars to members, members to PCPs, PCPs to larger provider entities. The insurers are going to report spending by the large provider entity. And actually, Tiffany, going back to the comment you just made, or question you just made, insurers are also going to report spending in aggregate for members who cannot be attributed to a PCP and for members whose PCP cannot be attributed to a large provider entity. So this is going to be the small practices. Okay, this makes sense. So as I said, members need to be attributed to a clinician for the costs incurred by that member. Attribution of health plan members to clinicians is routinely performed by insurers. They do so for contracts that they have, where the providers, the individual clinicians and provider entities are held accountable for quality and or the cost of care. Insurers also do this for other purposes, including internal care management and for doing analyses. Sometimes states and independent quality improvement organizations do the same thing. So if we attribute, or if an insurer attributes a member to a clinician, it does not mean that the member was required to see that clinician, or even that the clinician delivered all the care the patient received. All it's establishing is there was a relationship between that member and that clinician. So if Michael Bailiff belongs to Acme Health Plan is going to do an analysis and say, Michael got all of his primary care visits from Dr. Martinez during the past year. So we're going to make an attribution between Michael and Dr. Martinez, and Dr. Martinez belongs to Blue Mountains Medical Group. And so we're going to use Michael Baylett's spending to attach him to Dr. Martinez and to Blue Mountain Medical Group. Okay, so this attribution is establishing that there's a caregiving relationship, in this case between me and the clinician, with the understanding the clinician in some manner was directing the patient's care. There are two ways to do this attribution methodology. One is to say all payers should use a common methodology, meaning a common set of decision rules that attaches the member to a clinician. The strength of that approach is it allows for ease of comparison, combining data across insurers. But the con is it requires the insurers to all agree to use the same approach. And I think the starting assumption should be that they don't. We recently did an analysis in another state where we asked all of the payers to give us their attribution methodologies. They were all highly similar and none of them were identical. The other approach is to say, insurers, when you report your data to the state, use whatever your attribution methodology is. The strength of that approach is it's way easier for insurers. The downside is you might get some inconsistency in your results. You know, based on our analysis, I don't know that the differences in what insurers do, at least from our study in the one state, are profound enough to warrant trying to push for a common attribution methodology, but that is certainly an option. So let's go to Tiffany and then Flo.
I just have another clarifying question. Is duplication a consideration, and is it an issue if it is? Is there possible to see duplication in attribution?
No. So the way that the algorithms are designed is there's sort of a hierarchy of rules, but you can only be attributed to one clinician. Flo?
So Michael, is this an issue if you're using an all-payer claims database information and they all have to contribute the same information into that database?
Well, remember the reporting for the benchmark is not coming from the all-payer claims database, it's coming from the payers and in aggregate form. And the reason for that is the all-payer claims database will at best have half of the commercial population.
Okay.
Because the self-insured data won't be there.
Okay.
Okay. Yeah, and it also won't have non-claims based payments, won't have drug rebates, won't have some important information. Leanne?
Similar to Tyler Garner's question of duplications, are there chances that will be missed, right? So I'm a patient and I never go to the doctor, but I have benefit through this payer. I just don't actually ever show up, or I do show up, but only in urgent cares. And yet there is a PCP willing and able to see this patient, never actually sees them.
Yeah, great question. So that patient's spending isn't going to show up when we do the provider entity spending trend, but it will show up at the payer level, the market level, and the state level. Okay, but when we're doing provider entity measurement, we can only include those patients who have seen a primary care provider. If they've received no care, or if they're only receiving specialty or urgent care or ED, then we don't capture them.
A follow-up for that. So been seen or been paid? Because right, there are lots of docs out there who for timely filing,
yeah,
they were seen, but they were never paid.
Yeah, been paid. There's got to be a paid claim. Thanks.
That might be a problem, missing patients.
Yeah. I mean, none of this is perfect. Mason?
Yeah, so this is Dr. Khan. A quick on that subject. Patients end up in urgent care. I know some managed care are trying to educate their members, et cetera, to avoid, or talk to the PCP, et cetera. It adds to the cost basis of the managed care organizations when the patients land up in urgent care every second time they sneeze. And the availability of PCP, those who have a PCP, is a challenge. Number one, they cannot reach their PCP to discuss they've got a cold or a cough or a sneeze, and maybe the PCP could have taken care of it on the phone, and that is not happening. And then it adds up to the cost when they land up in the ED or urgent care. Any thoughts on that?
Yeah, that's all true. That's all true. And, and Tony made a point about shortages of clinicians. So, the fewer primary care clinicians you have and the larger their panels, the more difficult it is to deliver good care and reduce unnecessary spending.
Michael, Mason had a question.
Oh, yeah, and I just following along with Commissioner McAllister and Chair Collins, I think obviously we want to try to capture as much data as possible and attribute members where they are. And just for some of the new members on the commission, just a reminder that we still have a high uninsured or underinsured population that it's very difficult to attribute any primary care to. I think we're running probably close to 11% uninsured in the state. So, and we all know that care is typically delivered in those urgent care settings in the ERs, which is the absolute most expensive place you can probably get your health care. But just knowing that we may have to make some assumptions, and Michael, I know other states have got that challenge, probably not as high as Nevada. I mean, we're probably one of the higher Medicaid expansion states, but still have one of the highest uninsured populations in the country. So just for the other members, I think we're all leaning towards that same premise that we may have to make some assumptions in some other categories that may not be captured because it doesn't go through a normal processing of an insurance claim. Just my thoughts.
Yeah, that is a really high rate especially for an expansion state.
Tyler, you had a question as well?
Yeah, and maybe this would kind of go with the next slide where we're talking about picking this, but could I take a step back and I just want to understand for the purposes of the cost growth benchmark and just trying to track costs, why do we need to attribute it to a specific clinician and not just the cost of services that someone received or had ordered or that the payer was paying? Like, why does it have to go to a specific clinician provider group?
Because if we want to measure the performance of large provider entities, we can only reasonably hold large provider entities responsible for patients who are theirs. And so we have to find a way to attach the patients to them. Babette?
Kind of following up on that, I get that, but the benchmark might be useful for a lot of things. So is there a way, to Tyler's point, for things that can't be attributed to one provider to be in some other category as unattributable, or some way to measure them, some way to account for their existence that we won't catch if we're doing the attribution only?
Yeah, so I covered that a couple slides earlier. So
sorry.
Yeah, it's okay. That's all right. This is a lot of content I'm throwing at you. I appreciate that. So insurers are going to report spending by large provider entity. They're also going to report spending in aggregate for patients whose clinicians are not part of large provider entities. And they're going to report separately spending for patients who have had no primary care encounter.
Okay, so you were getting them.
We're getting everything.
Thank you. Okay, that's needed to clarify. I appreciate it.
Yeah. All right, so what have other states done on this question? So Massachusetts, Delaware, Rhode Island, Connecticut, and Oregon all used a primary care attribution model where they have allowed the insurers to use whatever methodology they're using internally. Massachusetts and Oregon went a little further, and they said that the carriers or insurers' primary care attribution method should follow a hierarchy. First, member selection of a primary care clinician, as you would find in an HMO design. 2, a contractual arrangement, so attributed lives, say to an ACO, and then 3, just straight utilization of primary care. So all of the states have decided not to require a common attribution methodology, but to allow payers to use their own. And 2 states went a little further and defined a required hierarchy for insurers to use when reporting data. Tony?
Thank you, Michael. And if I'm getting this attribution thing right, so the other example is what CMS did in terms of their attribution with the Medicare Shared Savings Program after the ACA, right? So they attributed with rules across the nation. Is that accurate?
Right. One standard way that Medicare did it.
Right. So Medicare said, hey, this is the approach, and that allows us then to compare and contrast. If an outcome, it's interesting for me, if one of the outcomes that we're hopeful for is the ability to compare, and that's what some of the other states have as their goal as well. Why do they not specify the attribution method? That seems so integral to the way you understand the cost performance.
Yeah, so I think they did some weighing, and they said, all right, in order to do this, every insurer in our state is going to have to do it differently than what they already do. And we find that the differences in the methodologies are not sufficiently meaningful to warrant the added requirement of the insurers. I think that's how they got there.
Got it. And then on the back end of that, though, you can't come back and say, if I'm a payer, you can't come back and say, well, wait a minute, I don't agree with the way the attribution was. Ours approach is different. You got to accept across the board. You can't have it both ways, right? If you give people the flexibility on the front end, on the back end, they can't use that as an excuse for why they're not performing at the level of the benchmark.
That's probably another reason. I hadn't thought about that, but yes, that's true. That's true. All right, so my question for all of you is, do you want to recommend payers report using their own? Using their own, but specifying a hierarchy, or using a common attribution methodology that would have to be specified by the state? Tyler?
So I'd like just to ask a question about, even before the insurer is attributed, won't we have just all the data already about what a patient, what care they received, and if there was an ordering physician, anything like that?
No, because the payers are reporting aggregate spending data. We're not getting claim level data.
Right. So, okay.
Is that what the other states are doing right now?
Yeah, all the other states gather aggregate data from the payers.
Okay.
Even states that have all payer claims databases, because the all payer claims databases don't have self-insured commercial, they don't have non-claims based payment, and they don't have drug rebates.
Okay.
Can I interrupt right now? We had a 10-minute break on the agenda. I don't know if anyone would like to take a break. Michael, if you need a break.
Yeah, Leslie, I suggest that we do it after we get a recommendation on this slide.
All right.
Okay. Are you
Does
agreeable
everybody
to that?
want a break? Everybody is quiet.
After
Michael,
this.
Okay.
Okay. We'll wait a minute then.
Tiffany?
Just let us know when, Michael.
Got a clarifying question. Depending on whether it's their methodology, one with a hierarchy, or some standard, do we create situations that have us comparing apples to oranges? And if so, how will we mitigate it?
Right. So if you have a common methodology, it's apples to apples. This is just my personal take on it. I think if you let everyone use their own methodology, it's a case of comparing Portland apples to Macintosh apples. So it's not identical, but the differences are awfully subtle and probably not substantive. I think like a little fruit analogy in a health policy conversation. Lenitra?
And that is why I believe it is more important for them to have a common methodology across the board so we all can compare apples to apples and not apples to oranges or Macintosh to Red Delicious.
Okay. All right. All right. So you're advocating for common methodology defined by the state. Great. Sandy?
I was just going to recommend either bullet point 1 or 2, just based on the, difficulty for the insurers to report and the differences being so subtle. I don't know that it's worth, like you said, prescribing a methodology if the differences are going to be that subtle.
Okay, thanks. Babette?
Sorry, I agree with that. I think that it's taken a long time to get this far. And I think for me, it seems like it's better just to get started and not try to spend a lot of time coming to consensus about how each measure would be created, because we have a tough time reaching consensus. But when I say that, would we be able to do it down the line? Would we be able to create sort of a time where we separate out the way that we're reporting, a few years down, and just kind of change tracks a little bit so that attribution could be consistent if we.
You could always decide. Yeah, you could always decide to do that subsequently.
Okay.
Yeah, you would have to give advance notice to the insurers, and you'd have to decide what's the common methodology. But yes, there's no decision you're making or recommendation you're making today that you couldn't change.
Okay, so I would say it's better for us to make progress than to try to reach consensus, because that has not been very successful here.
Okay, thanks. Dan?
Are the methodologies public and articulated alongside the data?
Yeah, great point. There's at least one state, please don't ask me which one, that went with insurers using their own, but also recommended that the insurers disclose what the methodology is.
Yes, I think I could support that recommendation as well.
Okay, Tony?
Yeah, I agree with Commissioner Bond. I think that getting something done here is important. Not only, I think, in reference to the last comment, I'd also like to see that they disclose their methodology. So I'm in favor of bullet 1, attribution, but we got to know what it is and how you're allocating. And this is a part leads to a question, Michael, the answer to which will inform my decision. I imagine at the end, given how little variance there is between using their own methodologies, that we're going to actually analyze and understand the sensitivity analysis around how, what their point estimate is versus what are the guardrails on that? What are the confidence intervals on that? Is that accurate?
So you could, I mean, that's not something that would have to happen, but you could do some modeling, especially once you've got an APCD, where you look to see, so using the APCD, how different would our results be? So that you can quantify my Macintosh to Cortland or Red Delicious analogy.
The real reason for that, if I'm thinking about this across payers, the answer to that seems to have relevance, for example, at the Medicaid program level, right? Where I've got a variety of providers or a variety of payers who are all going to be using their own methodologies, but I want to compare across Medicaid, for example. That would give insights for the state in a way that is different, but they need to know the kind of guardrails around the point estimate, the confidence interval. I keep talking in statistical terms. They need to know the confidence interval around the point estimate in order to compare Medicaid Plan A to Medicaid Plan B.
Yeah, right. Yeah. And in the future, when the state's got an APCD, it could easily do this. It could apply one attribution methodology for doing analysis. All right, so I'm hearing a drift towards letting insurers use their own, but disclosing what the methodology is. I want to acknowledge that Lenitra felt that we should move towards a common methodology. Anybody else want to weigh in? Okay, so I think that Leslie, this might be a good time for the 10-minute break. Oh, I'm sorry, Tiffany, raise your hand.
I'm sorry, just a quick comment. I appreciate Lenitra's concerns, having had the benefit of working in the state for progress. Also hear Babette, and since we have the opportunity to later do some analysis and determine if we should shift or tweak the methodology, support us moving forward with them maybe using their own methodology, and then at some defined period of time, reviewing what resulted and suggesting tweaks to the formula or process so that we account for both.
Yeah, so actually I want to build on what you said and what Tony said. What I'm hearing is in the future, perform an analysis to understand whether the differences in methodologies are substantive in terms of their impact and being able to quantify that. Okay, so that would go on our checklist for a future analysis under the data use strategy. Okay, great.
Okay, ready for a break?
Ready.
All right, then
Okay,
10:36. We come back at 10:46. Thank
Okay.
you.
Great.
Thank you. See you in 10.
So it's 10:46. We should get started again. Everybody online? All right, let's proceed then. Can you hear me?
I can. Okay. So we've talked about how to attribute patients to clinicians. Now we're going to talk about the second attribution question, which is how to attribute clinicians to larger provider entities. So payers will need technical instructions from the state on how to do this. There are two general approaches that states have taken thus far. The first is attribution based on a statewide provider directory. And as I will explain briefly, Massachusetts and Oregon have done this. And two, to do attribution based on contracting arrangements, and Rhode Island and Connecticut have done this. So here are some examples. So the first two examples are using a provider directory. So in Massachusetts, the state attaches provider identification numbers to physician groups. Okay, so they've mapped individual physician NPIs to physician groups. You can do this using tax IDs. You can also do it using both. Insurers then report spending for the identified physician groups. In Oregon, they don't have a statewide provider directory, and so they are building one through their payer submissions. So the state has asked payers to report provider organizations by their tax ID numbers. So not the NPIs, but the tax ID numbers. And they are building the provider directory based on the submissions. Oregon recently took in this past fall data for their baseline analysis. So for their pre-benchmark year. And so they're building their provider directory right now. The other approach is to use contractual arrangements. So in Rhode Island, the state's identified the largest accountable care organizations. This is a small state, remember? And so now these are all the accountable care organizations you see on the left. They contract both with commercial and Medicaid payers, some just with Medicaid and some just with commercial. And insurers themselves identify the individual clinicians that are a part of the ACO. Now, it's possible that different insurers will identify different clinicians as part of these ACOs. I don't know how common that is, but it certainly is possible. Tony?
Yeah, and Michael, with that, I want to make sure I'm staying on the same track as you. You're talking specifically right now about primary care, right? Because specialists could be members of multiple ACOs. So we're talking about the attribution at the primary care level.
Right. Yeah. So we're talking about how do you attach primary care clinicians to larger provider entities. So the first approach is you create a big database that literally maps every PCP to every medical group or ACO or whatever the definition is. The other approach is you have the payers report based upon their contractual arrangements. So let's say that, Acme Health Insurers got a contract with you. Their contract with you identifies who are all the primary care providers that are part of your organization. So that's what they're going to report on, not on a common directory, but based on their contractual arrangements. Okay, so this is what Rhode Island's done. Connecticut's done something similar, but a little bit different. So they've identified a list of provider entities based on feedback from their carriers. And these are entities with which the insurers might have ACO-like contracts or might not, but they have at least some type of value-based payment arrangement. And so the state, for its baseline analysis, picked just 11 of them. And these were the ones that had a lot of overlap in total cost of care contracts across carriers. But they're going to expand the number of assessed provider entities when they report their first year performance, which is 2021. And so, again, it's the insurers that are identifying the linkages between the primary care provider and what they are calling advanced networks in Connecticut, although they may not always be ACO arrangements. Okay.
So just a quick reminder for time constraints. So we normally like to wrap it up by 12 noon, and we are close to 10 to 11. So we have some time, but please keep that in mind.
Mm-hmm. Thank you. So I've given you a little bit of background. You might have some additional questions, but I'd like to ask you for your thoughts on whether you want to recommend that individual clinicians, primary care providers, be attributed to large provider entities using a statewide provider directory. There is right now no statewide provider directory in Nevada. So if you wanted to recommend that approach, the state would need to do something similar to what Oregon is doing. And of course, it would be dependent on state capacity. I don't want to presume state capacity. The other approach would be to ask the payers to report based on their existing contracting arrangements.
So quick
Certainly-
comment. So there is, sorry to interrupt, but the Nevada State Board of Medical Examiners has an extensive list of all the providers that does identify those who are active versus retired and still retired in the sense still have holding a license. So that's a basic general start for a list of providers in the state, but obviously it needs to be narrowed down to more specific areas in the state.
Tyler?
I think, perhaps pursuing a statewide provider directory and, something we can recommend generally could be beneficial just for patients in Nevada. So that might be something we'd want to pursue anyway. And if we're going to do that, it would make sense to attribute clinicians to provider entities underneath that. So I think that kind of makes sense. Contracting arrangements, at least it's there now, but again, you're going to have mix and match. It's going to be hard to maybe pin down a clinician to a specific large entity. Maybe not.
Yeah, I think a provider directory is sort of the gold standard. The ultimate question is going to be how feasible it is, because it's going to require some fairly significant work on the state's part to do it. Anybody else want to weigh in? Tony?
Yeah, thank you. I mean, if a statewide provider directory is the prevailing approach, that may give us insights for other things that we're troubled with, as well as I mentioned before, things like workforce, things like it will give us insights that are different. But it will be important for us to understand how much of a lift that's going to be for the state and whether or not it can actually be done and what time frame. Right? We don't want to go down a path where something can't be done. The question I'm going through in my mind is, yeah, I like that approach. Statewide provider directory for me is the way to go. Until people tell me it can't be done, then I'm really stuck with one approach. or more importantly, say it differently. Am I then, okay, so imagine that the state says, no, we can't do it. We don't have the bandwidth, we don't have the resources, et cetera. Well, then we're passing that along as another unfunded mandate to the contracting side of the house. And wait a minute, that doesn't feel right either.
Yeah, I mean, this might require Sandy and her colleagues to go do an assessment and evaluate what would be required. Babette and then Leanne.
That's what I was going to suggest, since we've got some support from DHHS and some representation on this commission. I think we should try to get their ideas about what's realistic and what kind of timeline and what kind of resources it would need. I share the concerns already raised. I think the information is always valuable. I don't know if it's valuable enough, I think we need to figure out what else we need.
Yeah.
And if I could recommend that it be considered as part of the annual licensing process for physicians, that they all have to renew and keep up their medical license here in the state to make their self-reporting for a statewide provider directory part of that process. Wouldn't happen immediately, but we certainly would get there over a calendar year.
Yeah, great idea. Sandy, do you want to share any thoughts?
Sorry, I was trying to unmute. Yeah, I think a statewide provider directory is beneficial for a lot of reasons, and has ties to a lot of the projects that DHHS is interested in. But we would need some time to evaluate how much time and money it would take to stand something like that up.
Okay, all right. So it sounds like there's support for that idea, and perhaps in the future we could come back and give you a status update after there's been an opportunity to spec out what would be required to do it. And then if not, the fallback would be to use the payers.
Yeah.
Okay, great. Yvette?
I'm just thinking there's also some other data that we want from what's going on, like I mentioned earlier. So maybe there's a way when the state considers this to see what else they could put in this directory so that we can get a more accurate snapshot than we have now.
Yeah. Thank you. Okay, so I'm going to transition now to methods to ensure the accuracy and reliability of benchmark performance measurement. We may not get through all of this in the remaining about an hour that we have to talk. And so we'll pick up next time where we didn't get. So we talked about this a little bit earlier, the problem of small numbers. And specifically, the problem of small numbers is that random fluctuations in service use and hence in medical expenditures will have some substantive impact on per capita cost growth when we're measuring entities with small populations. And when I say small populations, I mean small from a statistical perspective. You all might say 2,000 patients, that's a huge population. Statistically, it's tiny. And you're going to see all sorts of random variation if you have a population that's only 2,000. Okay, so we're really talking about small populations from a statistical perspective. Payers and provider entities have to have a sufficient population size so that we can detect changes in annual per capita medical expenditures accurately and reliability. And we want to minimize the effect of the presence or absence of a few unusually complex and expensive patients on an entity's benchmark performance. So we've talked to date in this, or henceforth in this meeting, largely about provider entities, but this applies to payers too. You could have a payer that has a relatively small member population that would be impacted by random variation in medical expenditures. So if we're going to measure benchmark performance, we want to make sure that we are not going to unfairly assess a payer or a provider entity due to the impact of random variation. All this make sense? Or any further? Yeah, okay. So there are a bunch of things that can be done to reduce the chance that random variation is going to impact the results of a performance assessment. And when I say performance assessment, just to be direct, I mean reporting publicly entity A did or did not meet the benchmark. That's what we mean by performance assessment. So there are 4 different strategies, and I'm going to work through them sequentially. Again, I may not get to all of them today. So when we are considering these strategies, we want to make sure that we're balancing having a high degree of confidence in our assessment with reporting burden by payers and with state staff burden to do the analysis. Okay, because in order to be more confident, we have to do more work, just to be clear. So I'm going to start first with the concept of statistical testing on benchmark performance. So one idea is to develop confidence intervals around benchmark performance. So a confidence interval shows the possible range of values in which we're pretty confident the true value lies. And so it would allow us to be able to say, for example, we are 95% confident that between X% and Y% is the true rate of growth for Acme Health Plan. Okay, that's what the confidence interval does. So here's an example. This figure is not drawn to scale. So this is our confidence interval, and pair A right here crosses over the 3.2% growth line. So it means that the rate of growth for pair A might have been below 3.2% or might have been above. More likely above, but possibly below. So for pair A, using a confidence interval, we can't be sure about whether or not they met the cost growth benchmark. Pair B, their confidence interval, that's what this line is right here, it's completely above the 3.2% cost growth benchmark. And so we can say with certainty that pair B did not meet the benchmark. And finally, provider organization C, this is their confidence interval. It's much smaller than for pair A or pair B. It's completely below or to the left of the 3.2% growth line. So we can say that we are confident that provider organization C met the benchmark. Now I'll note that we're going to see larger confidence intervals for smaller populations, and we're going to see much narrower confidence intervals for larger populations, because we're much surer about the performance when the population is large, and we are much less sure when the population is small. So Oregon, Connecticut, Rhode Island are the first states to use confidence intervals. Oregon developed the methodology, which Connecticut and Rhode Island adopted. All of them are right now analyzing their data for reporting. It says in early 2022. Frankly, in Connecticut, it's next Monday. So that's really early. Washington has adopted the use of confidence intervals. They only just did so, and they have not yet started to commence baseline reporting because their cost growth benchmark just became effective. Massachusetts doesn't use it because their methodology is in statute and they can't change it unless the law changes. And Delaware hasn't used it because they've only been reporting at the state and market level where you don't need it. Tiffany, do you have a question?
Just to clarify my understanding of what you're sharing with us, the first clarifying question is there a process by which we can identify and mitigate outliers? Because I think that's kind of what you're speaking to about smaller populations. And then also this discussion about the confidence intervals, in some ways are tied to error, a measure of error, right?
Right.
And so we're saying that there's a level of confidence we can have about how accurate it is. And so I'm wondering if that's the case, like, are there reasons why someone would not do that other than by statute they cannot or something? We should have some sense of kind of how, or expectation around how accurate it should be anyway, right?
Right. Right. No, you are correct. It's hard to find an argument for not using confidence intervals, except that the law prohibits you for it, or you just never thought about it. Because the confidence interval allows you to say, we're pretty sure that this organization did or did not meet the benchmark. Whereas otherwise you might say that they did or didn't, when in fact you're not statistically confident in that statement. So that's why it seems like a no-brainer, but it's still something that we need to talk about with you. We are separately going to talk about what to do about high cost outliers. And I'm going to get to that shortly. This does not address it, except to say that you might have a really broad confidence interval, in part because you've got some outliers. And so we're not going to make a judgment about you, but it doesn't really mitigate the impact of the high cost outliers. Okay, so I think Tiffany's already given her opinion on this question, but I want to ask the rest of you, do you recommend the application of statistical testing and the use of confidence intervals to determine benchmark performance? Tyler.
Just real quick. So if I'm understanding, for Massachusetts, they just report the data and there's nothing specifically addressing their confidence levels, or is there something separate in their methodology that kind of addresses this issue?
No, they don't. In fact, I showed you a graph earlier at the little circles. Yeah, there's nothing there to indicate the statistical confidence of those measurements. They just say you're above or you're below.
Okay, and then, sorry, and just personally, I probably makes sense. We'd want to analyze and see how confident we be in the information. I just wouldn't know how to do that. I think we need more information on what that looks like. I guess what maybe Oregon's doing.
Yeah, so it's not complicated. It's a really simple statistical exercise to determine a confidence interval. So we were just talked about the membership directory and how that's a big lift for the state. Confidence intervals are not a big lift. Tony? And then
Michael, thank you for that. That's what you've just done in the last couple of slides was the best explanation of confidence intervals I've heard in decades. So thank you for that. But I guess, again, to the point, this is standard statistical approach. We're not talking about something unique that we're developing only for the benchmarking in the payer space. This confidence intervals are sufficiently validated across the scientific literature in a way that allows us to reduce outliers. And I know we're having another conversation on that, but to understand if our estimates are actually within the frame, real differences or not real differences. And I think that is
right.
I'm all for it. You got to have statistical legitimacy if you're going to hold people accountable. And without this, the whole program falls down.
Mm-hmm. Yeah, I agree. Babette, and then Yarlene.
I'm thrilled to agree with Dr. Slonim. Thank you.
Yarlene?
And I would like to say that I support as well using competency intervals too.
Great. Okay. Thank you all. All right, so now let's talk about high cost outliers, which you are all interested in. So high cost outliers are members or patients, depending on who we're measuring, who have super high levels of spending. They, for the most part, present randomly in a population, and there are often limits on how much their spending can be influenced due to their medical condition. I would say as a general rule of thumb, it's not fair to judge insurers or providers against the benchmark if they happen to have had a number of high cost outliers in a given year. Because those high cost outliers will have frequently a meaningful impact on what their trend rate looks like. Babette?
I get that, but I also think it's really important that we make sure we can find them and analyze them and we have them, because we don't know if that's related to price or if that's related to lack of care access or if that's related to out of state. We don't know this is one of the things we have to understand better. So how would we be able to see those if they're excluded from the trend, which I get outliers usually are excluded from trend. But to a lot of the conversations we've had today, we need to find all this data for other kinds of problems that we have in the state. And I'm hoping that we still can find it.
Yeah, so, again, my favorite topic, the data use strategy, which is the complement to the benchmark analysis. You could do an analysis with the future APCD of high cost outliers and what do they look like and who are they and why are they? I would say that generally speaking, it's not going to be price except when they are high cost outliers because they're on an extremely expensive infusion drug, because there are some high cost outliers who fall into that category, which that category didn't even exist a few years ago. So it's generally not going to be price. It's generally going to be intensity of service utilization, whether it's in state or out of state.
So on the high cost outliers, couple of observations. Number one, generally speaking, and Babette, you can correct me if I'm wrong, managed care organizations do have negotiated rates with the facilities and providers, especially the facilities, for a cap on the high cost outliers or a negotiated rate on the outliers. Number one. Number two, on the high cost outliers, besides the cap, whether it's $1 million or whatever, how good it is or not good in that occasional case, and believe me, there are some occasional cases where they hit beyond $1 million, hospitalized for multiple issues, et cetera, and it's capped at that level. But Babette, you have the experience. Could you chime in on that?
Yeah, I think we look at the outliers all the time because we want to see what really happens. So I just want to make sure the data is there. To the first issue, we don't know what we don't know. But you're right that when managed care contracts, we will try to set some of those parameters, but it just depends on the entity that's being contracted with. It's a two-way deal, and if the providers and the insurer can't agree on how to do that, then it doesn't get done, and that's increasingly happening. I'm sure you're seeing that too, Dr. Khan. It's increasingly difficult to come to agreement, and so there's more and more left unfixed.
Right, and then the carve-outs go only so far, and the new medicines and technology keeps coming up, and one doesn't know how to carve out. Just the example comes to mind is ECMO. It's not so new, but it's a pretty expensive venture. And these days with COVID, many patients are on ECMO. I mean, this is an ongoing phenomenon of carve-outs also. You can go only so far with carve-outs, and then becomes a challenge for the managed care and all the providers. How does one determine the carve-outs and what limits? So it's a complex issue, like you said, Babette, between the managed care organization and the providers. So I don't know how we will be able to at least delve into it, if not find a solution.
Yeah, we'll need to try to track. That's why I want to track them. I'm really finding too that the increasing scope of what we have to cover as a health plan to protect patients, which we want to protect patients, but we have to cover as a mandate from the federal government, like all this COVID stuff. We don't get to negotiate any of that. So we're contained in that we have to pay all of it, but there's no containment on the other side of how much can be charged for it. And so we're having more and more issues with the difference between cost and the difference between price and who pays. So that'll be a future topic.
Yep.
Leanne?
I would be comfortable with mitigating the impact of the high cost outliers if there's transparency, if we can know who those outliers are, because if they truly are one or two patient outlier, that's fine, but they could be a small group of patients that are being overlooked or are minoritized in some other way that need to be an important part of the data analysis.
Yeah, so let me share what generally is done here, because they're not usually fully excluded. So what's typically done in contracts between payers and providers is that their expenditures are truncated, meaning you're setting a limit on how much of the spending is included in the calculation. The truncation is usually at an annual spending level by patient. For a commercial population, it's set at 100 to 150,000. Obviously, as Chair Khan just indicated, there are some patients that go way above this. So you are including the spending up to these levels, and then excluding everything above it. And I've given you examples here for commercial populations, but the same concept applies for Medicare Advantage and for Medicaid. All right, and I think this I just covered in my last comments. So in terms of other states, in Rhode Island, they initially did not truncate high cost outliers. And they looked at performance, and there was one ACO in the state that said, there's no way our trend is that high. And they objected to the data that was presented to them. And so some follow-up analysis was done, and it turned out that their high cost outlier spending raised their trend rate by several percentage points. Okay. Well, just think about that. If you're setting your benchmark at 2 or 3%, several percentage points is a ton. So the high cost outliers make a real big difference. And so there was this dissonance that this ACO was experiencing because they were looking at their experience in their TCOC, stands for total cost of care, their total cost of care contracts, where they knew what their trend was and where it was truncated, and comparing it to what the state was reporting, and they didn't align at all. Created a lot of confusion and some ill will. So for this reason, Rhode Island introduced high cost outlier truncation, starting with their performance data for last year, for 2020. So my question for you is, do you wish to recommend truncation of high cost outlier spending? I'm not here suggesting dollar levels for that. That would have to be figured out subsequently by the state, probably in dialogue with provider organizations and payers. But do you support the general concept of truncating high cost outlier spending? Tony?
Thank you, Michael, for the explanation. Can you go back to that last bullet point on Rhode Island for a second to help me with this? Rhode Island's truncating high cost outliers where? Consistent with their previous approaches, or total spend, or where are they?
So they engaged their health plans, and they said, tell us, essentially, where are you truncating spending in your contracts with providers today, and how does it vary by commercial, Medicaid, and Medicare? And they got input from a whole bunch of health plans, and then set standard truncation levels for the payers to use when reporting to the state.
Okay, good. Thank you for that. Based on that, so my answer to your question was, would be, I think that we should use an outlier approach. We should figure out how we exclude outliers, determine later, figure that out. And that's consistent, I think, with where we are now. I'm also sensitive to Babette's point about that's where the money is, no pun intended. That's where the opportunity to reduce the cost escalation is going to come in. So let's not lose the data by virtue of the fact that we haven't included it in the benchmark for now, because it's likely that that's where we're going to find the issue. And the rationale I've got for that decision is, especially as we're new at this, I also don't want to restrict, that's a good word, or deprive people of potentially life-saving therapies because they happen to be expensive, right? And so you would hate to be in a place where, because it's a high-cost case, people are not providing the drug, they're not providing the therapy, they're not providing the other things when there's a potential for benefit. So we all talk about that a lot in terms of restricting access, and I think that's a bad approach, which is why I would just stay consistent right now with outlier exclusion until we become smarter at the approach.
Mm-hmm. Thank you. I want to know two things. One is the the truncation proposal is only for measuring performance at the insurer and provider entity level. So it's included at the market level. The full cost is included at the market level. It's included at the state level. This is just to say, if we're going to judge insurers and provider entities, let's not judge them when influenced by the high cost outliers. The second point I want to make is I'm thinking about this data use strategy list of analyses to be performed. So another one is potentially to dig into high cost outliers, as Babette also suggested, and better understand the nature of that spending and where there might be opportunities. Tyler, and then Tiffany.
So I feel like we have to kind of see some data before we can make a really informed decision on this, because if this is just at the performance assessment level, perhaps we get all the data and it shows us that there are these, lots of high cost outliers, or maybe there's not any. And I don't want to limit how we review the information now before we even know what it's going to look like. I was also kind of curious because we saw Rhode Island. Do other states approach this differently? Like Massachusetts, I guess would be the big one.
So again, Massachusetts can only do what's in statute, so which is horrible. I will say that that we found the impact of outliers so compelling in Rhode Island when we analyzed it that we have brought this topic to the attention of all the other Peterson-Milbank states, and so. Washington recently adopted high cost outlier truncation, for example, and I suspect there will be other states that will do so. I'm bringing this idea to you because sometimes it's beneficial to not be first doing something, and in this case, we just learned from Rhode Island that you just get tremendous distortions at the insurer and provider level, which result in what I think are unfair judgments. And I will say, Tyler, we know there are high cost outliers. I don't think there's any question about whether they exist. It happens in any population. And so they certainly will exist. I don't think we need to see data for that.
I'm not saying that it would exist, but just for I don't see the value of taking that away from the total cost of healthcare spending when we're actually reporting the data at a public level.
Yeah, so we're not excluding it at the market level or the state level. It's only when assessing whether or not insurers and large providers met the benchmark.
Mm-hmm.
And it's only to be fair to them. To the point that Tony made earlier, if the assessments are not statistically grounded and fair, then the whole policy, stands on shakier ground. Tiffany, and then Sandy.
So I would support truncation with one assumption and one caveat. My assumption that what we're talking about is merely a methodology for reporting, like talking about what has already happened. And so with truncation, if I go with truncation, I'm not totally pulling it out of the data set, but I am reflecting or somehow accounting for it. There may be some higher trends or data points happening somewhere. And if that's the case, if those assumptions are right, then I would support the truncation so that I don't lose that information totally. But I would also want to do a separate analysis at some other time just to see what is happening there to help me contextualize what is happening when I have an outlier, particularly if I saw some clustering in a region or around a particular kind of treatment or approach or some of those things so that I could pivot later. So I would say yes to the truncation so I don't lose that information, but also that we should have an expectation around periodically visiting what is happening there to contextualize it and then use the information to inform our practices moving forward, if that makes sense.
Mm-hmm. Yeah, and that seems to be consistent with the words, if not the sentiments, of Babette and of Tyler. Okay, Sandy.
I just want to agree with everything that's been said, and I do recommend truncation.
Thanks. Okay, Babette.
Michael, thank you. Are we going to end up making a recommendation here? Because I do think it's important to make sure we're saying truncation, but with these caveats where we've got to capture the data elsewhere and we've got to include where to analyze it, because they do tell us things we need to know.
Yeah, I hear supporting truncation and also recommending that there be analysis of outlier spending to identify its causes and potential opportunities to slow spending growth.
And I just to really clarify this point, that this is something that the state would be doing with the data. We're not permitting the providers of this information to exclude based on these truncation numbers, are we?
So all measurement against the benchmark comes from the payers. So the payers would be submitting data at all these different levels, but it would be truncated at the provider entity and at the insurer level, not at the market level, not at state level. The analysis of outlier spending would not be part of the benchmark analysis. That would be part of the separate data use strategy, which in the short term is going to involve mining Medicaid data and PEB data. And in the long term is going to, or longer term, not long term, is going to be based on using APCD data.
So I'm still not clear on
Me either.
when payers submit the data, are they going to be excluding the higher outliers when they give it to us, or will the state?
They will for the payer level and the provider level data. They will be told to truncate only for the data that they are reporting at the provider level and at the payer level. And remember, they're reporting in aggregate.
They're reporting what? I'm sorry.
In aggregate. They're giving aggregate spending.
Because we won't have all the individual claims, so the state wouldn't be able to do that truncation. Is that correct?
Right. The state is not doing, the state is only analyzing what the payers are submitting in aggregate. The state is not getting any claim level data.
So Michael, if that's being truncated at the payer level before it's submitted to the state, then we're not going to have that data to review from what Tyler's asking and the way you're responding. So
right, but you never would, because it's only coming in aggregate, Babette, and the type of analysis that you want to do to understand the high cost outliers, you're going to want to understand, so what services are they using and what diagnoses do they have and where are they receiving their care, right?
Right.
That's not coming in from the payers. They're submitting aggregate spending totals.
Okay, so when we keep saying that we're going to be able to do this in this separate analysis, we're not going to be able to do the separate analysis.
No, you are. You are. You're just using a different data source. Remember that slide that I had that had two different columns and said there's benchmark analysis and there's data use strategy?
But if the data use strategy only is reported in aggregate, how do we ever do that?
No, it's not. No, so the data use strategy mines individual claim level data. And ultimately, that's going to mean using APCD data.
But you just said that, that it's only going to be reported in aggregate. So how does it get to the detail level? I've gotten lost, I'm sorry.
Yeah, so I have to go back too many slides to get to that table. And I understand the confusion. There are two separate types of analyses that are being performed.
Right.
Measurement of whether or not the benchmark was met.
Right.
Is aggregate data that the payers submit. All other analysis, which I put under the umbrella data use strategy, all other analysis is performed using claim level data.
Okay, but you're saying also in this list, right, that's what I thought, but you were also saying that claims level data doesn't come from the payers. So where does it come from?
Oh, it does. It does. Claim level data comes from the payers.
Okay.
Okay.
That's where I
Not-
think we got
but-
off here.
But not as part of the cost growth benchmark. It's
Right,
It's
not
if
as
we-
part of the cost growth benchmark.
It's if we are able to implement the all payer claims database. So there's no guarantee that what we're doing here, that we would actually have that data from the APCD.
Well, I mean, I think you will be implementing an APCD.
Yeah.
Okay. And
That's
so
passed, and that unless that got revoked in some way.
that's your data source for looking at high cost outliers and all other topics of special interest. It's your way of digging down into the benchmark data and finding out what's really going on. So for example, if you find out that pharmacy is what's driving spending and you want to understand why, you'd have to go into your all payer claims database. If you find out that professional spending is driving spending growth, you'd have to do some more detailed analysis using the all payer claims database to find out, so for what specialties, what diagnoses, what parts of the state, all of that's got to come out of the APCD analysis under what I call the data use strategy.
All right, thank you. Any other questions? Just reminding our time constraints. As you know, I'm a stickler for time out of respect for everybody. So let's proceed now. The other thing, I don't even want to rush things. As you said earlier, this is a very important deliberation. And if we don't finish today, and I'm sure the commissioners will have a lot more questions, which is crucial to decision making, then we can certainly carry on a limited discussion next time in areas where additional information, et cetera, is needed to come to a conclusion.
Chair Khan.
Can't you let people whose hands are up go though? Because I think now I feel like I took all our time, and I think that Commissioner McAllister and Commissioner Rodugan should have not asked for much and should have a chance to get.
Yeah, that's important. So you have to raise both hands sometimes.
Just quickly, I certainly understand in truncating data and that the details are going to be worked out later, but I think what we're all kind of circling around is that we don't want to see, from a patient's point of view, that institutions are hiding high profit centers in these outliers. And as long as we put on the record that this tool cannot be utilized to do something like that, that would make me feel better in accepting the truncated high cost outliers.
Okay, there was another member who wanted to ask.
Yes, Lenny. I just want to clarify. So the report, the way that we're reporting, you said we have the benchmark analysis versus the data use strategy. And I don't understand if we have to choose between these two or we're using both.
Both.
We're using both.
Both.
Okay. So we will have the information for both.
Right, because the benchmark analysis won't answer all of your questions. You'll look at it, as I said, you'll see one category of spending is growing, and you'll say, well, why is that? And we won't know from the benchmark analysis.
Right.
And so you'll need that additional analysis of claim level data to figure out the answer.
And my second question is, you're asking the commissioners for recommendations. We are not all telling you what we recommend at this time. So is there going to be a time where we vote, or how are you deciding on that?
Yeah, I can answer that. As I said earlier, we have to, it'll carry on to our next meeting, and additional questions or issues will come up. We'll pick it up where we will leave today. And even on the information from today, commissioners may have additional questions or input. When everybody is fully satisfied with their input and incorporation of new thoughts or ideas or deletion of certain things, that's when we should eventually end up voting after full deliberation on every aspect.
What I am hearing though, Arlene, I'm hearing that generally people are comfortable with truncation. They just don't want this high cost outlier spending lost, and they want to understand it.
So if I may suggest, as you are capturing the input of the commissioners, perhaps in our next meeting, when you come up, if you can put some of these thoughts that majority of us are thinking about, just put them in parentheses. And then at that time, we can say, okay, this was the recommendation of majority of us, should make it final, or if there's any additional thoughts at that time. So we don't lose track of what the thought process was today.
Okay. Sandy?
I was just going to ask if there's a time frame associated with these recommendations that we need to be aware of, because I know we didn't meet for a while because we still don't have an executive director. So I just want to raise that as something that we need to address when we need to respond.
Yeah, I think if we can come to closure on everything that we had teed up for today by the next meeting, we're okay.
Okay, thank you.
Tyler?
So just one clarifying point. So if we're concerned about if we don't truncate the data or allow payers to truncate the provided data, wouldn't we also be able, so say if we didn't do it and we got all the information, couldn't we then also just use the APCD to find those high outliers as well? Just the opposite of what you were saying before?
You can use the APCD to find the outliers. It's going to be a laborious set of analyses that someone's going to have to conduct.
But how would that be harder than the opposite of us trying to find what the real cost of those high cost outliers are when it's reported?
You can, yeah, you can do that. And if you want to leave the high cost outliers in, you can. You will have some payers and providers who will protest that the figures that you're reporting are not legitimate.
Right, but wouldn't patients also protest that the numbers aren't legitimate as well?
I don't think so. Sandy, and then Tiffany.
Sorry, I meant to lower my hand. I didn't have anything additional, sorry.
Okay, Tiffany.
Got a clarifying question, particularly the relationship between outliers and the confidence interval. And I think I'm assuming that where outliers or significant outliers are present, that the confidence interval becomes larger, or
right.
Yeah, essentially
right.
that measure of error becomes greater because the outlier is present.
Correct. It will be harder to determine whether or not a provider entity or payer met the benchmark or did not if outliers are not truncated, because as you know, the confidence interval is going to get wider. All right, Chair Khan, it sounds like we have not reached closure on this, but noting what the time is and noting that the next topic in my presentation is going to take some time, I want to suggest that we stop here and we'll come back to truncation of high cost outliers and to the additional topics at our next meeting.
Okay, I appreciate that for sure, but what I would request my fellow commissioners is hopefully at our next meeting, based on today's discussion, if we come back for some more thoughts or clarity in our own minds that we may want to digest before the next meeting, that'll help speed up the process next time, at least on the subjects we have covered today. And then you'll have, of course, a ton of questions on the new additional information rather at the next meeting, so that we hopefully wrap up as much as we can at that time. I know it's an important aspect of our deliberations for the governor, and certainly for a lot of our members. We would like to get this sorted out in a timely manner, but at the same time not rushed overall. Any other thoughts from the commissioners? Anybody with the hands raised? Because I can't see that. If none, then I think we could proceed with our next item. So
Our
our next, go ahead.
Sorry. Our next item would be public comment.
Do you have any comments in the north?
I don't see anybody raising their hands.
Anybody in the south in person or online?
I don't see anyone.
Okay, thank you, Leslie. So before I wrap up, we talked about a next meeting agenda item earlier in our deliberation. So Leslie, could we incorporate that at the before the next meeting in a timely manner for public information?
Yes.
I'm sure you have notes of the item that was put forth for next meeting discussion.
Did anybody have anything they wanted to add to what we've already discussed?
Yeah, I think Tony or Mason had some thoughts that we said, let's put it as a separate agenda item.
And Mr. Chair, if I could, this is Mason. I think what we were trying to convey in the combination of all the commissioners at that time, is there anything that we could do more immediate under some type of emerging issue, because we've got so many emergency orders going on. And I reflect much like the governor task force on COVID response, which I think is disbanded, and the chair by Jim Murrin, who did an excellent job of just coordinating resources and really fulfilling some of the needs on the behalf of the governor. Is there anything that we could assist or pick up with in regards to priorities related to patients and protecting patients during this delicate time of high unemployment and high positivity and inflation and all these other things that we can do on rising costs and access? So I think I was trying to convey that if we could relook at our priorities and see if there's anything that the group can make suggestions to assist the state in their response and recovery. Again, much like the governor's task force on COVID led by Mr. Murrin.
So specifically, do you have any language for the agenda item, or you can share it with Leslie later so that it's put up for public display in a timely manner?
Well, Mr. Chair, then I would, as far as language for Leslie, is just having an opportunity to discuss the emerging items around COVID response and protecting patients at this time, and kind of relooking at our priorities. So that's kind of, I was just looking for an avenue to have some deep discussion on what we could do as a body.
Okay, Leslie, you got that gist of it?
Yes.
Okay, perfect. So having done that, I think it's time for adjournment.
On that agenda item, can we request that the state of Nevada give a report on other parts of the state government that are already working on addressing the emerging issues, so it doesn't become too much of a distraction for the work at hand for this commission?
Any thoughts?
Leanne, just I appreciate that, and the state has done an amazing job, and I probably sit on 2 calls a day with the state looking at nursing homes and shortages and staffing and just drug manufacture, monoclonals and testing. And so we certainly do not want to duplicate, and if there's anything that this body could do to support the state in those efforts, but they've done an amazing job on advocating all the way up to the federal to very local municipalities. So, but I agree, we certainly don't want to duplicate, but there are a lot of things that, I get the opportunity to get privy to because of the emergency response.
Okay.
Dr. Khan, this is Jacqueline. I would like to add, I agree with Leanne. I would like to know what the state is doing so we don't have to replicate, but I also would like to add to what Mason is saying. And if we can have a discussion on the workforce issues, specifically the nursing issues in the state, and how could we recommend something for the governor to do in this case?
Okay. Any other thoughts from any other commissioners for the future agenda item?
Dr. Khan, I really appreciate the idea from Commissioner McAllister about having the state give us an overview of what's been done. I don't know how much work that creates for them, but for example, Director Whitley might be able, since he's already among us, might be able to take that on. I don't know who else we could hear from. I don't want to I don't want to add to your workload, Director Whitley, but.
He loves the workload.
Certainly. We can provide an update at the next meeting on not only what the status is, but some of the actionable items that have been identified.
Okay, great. So that would be incorporated for the agenda item next meeting. If no, go ahead.
Just two comments I would make. One, I certainly appreciate all of the work and the combined efforts that the state is doing to make sure that we're, as Nevadans coming through this. Just an observation point, we've just spent 3 hours on the phone talking about costs, and I don't want to duplicate work either, but we're in the middle of a global pandemic that is impacting our ability to deliver care for citizens of Nevada, and we have not addressed the topic. We just spent 3 hours together. We need to address the topic, and I think workforce, nursing workforce is in crisis. The new provider workforce on physician report has just come out last week. We are worse off than we were before. And our ability to provide care throughout the state is limited because our interactions between primary care, acute care, subacute, skilled nursing care is not integrated. Our approach is not integrated. So I'd love to learn more about that as we move forward. I think the other thing for me that is really a crisis, I think is probably a separate agenda item, is the state of mental health in the state is in crisis. It's in crisis made worse by the pandemic. We are 51st in the nation. Our adolescents and our children are struggling, and I can't tell that there's a plan, an approach, an effort in organizing our efforts around that. Everybody's tired and fatigued and frustrated, and we've got adolescents killing themselves at a higher rate than ever before. They're clogging up our children's hospitals and our emergency rooms, and we have a need to act on that. And I think it's important, as important a topic as any other that we might address as a patient protection commission.
So I think we will allocate time, hopefully enough time for the thoughts that you have so clearly identified. So even in the thoughts that you've identified, one has to further prioritize because we have so much time to address. So we do the acute, and in the acute issues, 1, 2, 3, 4 as a priority 1, which is really urgent or emergent, and then there's urgent, and then the subacute situation that one still needs to address. So hopefully in the next agenda item, we can list them, and then we can decide which item to address as number 1 and number 2 and number 3. All right, any other thoughts before we wrap up?
Our next meeting should be on February 16th, just in case anybody didn't have that on their calendar.
Okay. If that's the thing, we can wrap up and call for adjournment. We stand adjourned.
Thank you.
Thank you, everybody.
Thank you, everybody.
Thank you.
Thanks.